first thing I'd like to say is thank you, IAGE, for inviting me. I am going to stick to time because you have two very important speakers after me, my very good friend Gunter Noy, and another speaker on lap called Posecropexy. So with respect to them, I will stick to time that has been allocated to me. I think it's 25 minutes. The first thing, actually, Sunita, I would like to say is one of the things
not said, sir.
You people need to look at is a webinar to support people's health during webinar, because we're all getting webinaritis. And I think there should be some yoga, some body loosening that should occur during every single session of webinar. Okay, enough about that. The next question was, I was participating in the last talk and someone just asked, did you ever find a Krukenberg tumor with an endometrioma? Actually, I just found one last week. And so yes, they do actually tend to coexist. But more importantly, we'll move on to the topic at hand, which is stress urinary incontinence. A very challenging topic, obviously, because you are laparoscopic surgeons, and to take your brain away from endometriomas is going to take a huge step for you to understand this change in how we are going into urogynecology. Now, urogynecology, very simply...
Doctor, sorry to interfere. Can you please share your screen?
Is my screen not being shared?
No.
No, doctor, it's not being shared.
It's not
My
visible.
apologies. I need to go back and do the right thing. Why is that happening? Support is asking permission for remotely control your desktop. You can do that.
It is visible, sir. It is clearly visible.
Can you see my
Yes.
slides now?
It is visible, sir.
I don't know what happened. It must be Auntie Sunita who caused the problem. Anyway, sorry guys, you didn't see my handsome face.
Can you
This
put
is,
that? Can you put that on presentation mode, please? Full screen.
God, he's like my mother-in-law. Hang on, I don't know how to do that, but I'll try. There's this thing coming in here.
Just enlarge, just enlarge.
Yeah, I'm trying to do that. Is that better?
No.
No.
The screen symbol just next to that.
But you know, your command bar is coming in my way. So I want to move this command bar somewhere else. I'm clever. I know how to do this. Okay, I can beat computers. Thank you. Is that better?
Yeah.
Yes.
Okay, thank you. Sorry, Australians are a bit slow. And then Indians in Australia is even slower. Okay, so let's go to stress incontinence. It's a complaint of involuntary loss of urine on effort, and it is sudden physical exertion. I think you need to understand what sudden physical exertion is very important, not chronic physical exertion. So it's a sudden increase in intra-abdominal pressure. Urogynecologists look after all three orifices around the vulval area: the urethra, the lower urinary tract, the vagina, the genital tract, and the lower gastrointestinal tract. So all these actually are combined. That's why the understanding of the pelvic anatomy is very necessary. I'm going to devote about 10 minutes on pelvic anatomy, 12 minutes on the specific topic itself. And we are going to skip videos because I think you should look at the videos of the next two speakers who are absolutely amazing. So if you look at the pelvic diaphragm or the pelvic anatomy, there are three layers of muscles that you traverse. The pelvic diaphragm is different from the levator ani complex, is different from the perineal body. I did not want this to be an interactive session. I did an interactive session last week, but I want to actually ask you this question. So what do you think happens to your levator muscle when you cough? And what do you think happens to your levator muscle when you do a Valsalva? Very interesting concept. I want you to think about it for 5 seconds because the answers are coming up now. Basically, if you look at the pelvic anatomy, the puberrectalis, pubercoccygeus, ileococcygeus, and ischiococcygeus form the levator ani complex. This complex is at the junction of level 2 and level 3, which is the middle third and the lower third. So it is not at the opening of the vagina. At the opening of the vagina, you actually have the urogenital diaphragm, and you have the external urethral sphincter and the sphincter urethrae compressor. So these intrinsic sphincters of the urethra are extremely important for what we would call intrinsic sphincter mechanism. So two mechanisms that we want to understand for urethral support. First one is the pubo-urethral ligament that goes from the surface of the symphysis pubis and encompasses the urethra at the level of the mid-urethra. So you need to understand that the mid-urethra in the female is the continence mechanism. The bladder neck, where the urethra joins the bladder, is the voiding mechanism. So we should always mark the bladder neck when you're performing surgery, understanding that the bladder neck is like your mother-in-law. You must avoid at all costs. So if you want to do an anterior repair, you go below the level of the bladder neck. If you want to do a suburethral sling, you want to go above the level of the bladder neck. It is no surprise that when you do pubovaginal slings using fascia, or when we used to use Gore-Tex slings at the level of the bladder neck, we would have around a 20% voiding dysfunction. So I think it's very important to understand the three levels of the anatomy. The deeper anatomy at the junction of level 2 and level 3, the opening anatomy of the external and compressor urethral sphincters, and the perineal body. All these three form a crucial part in the mechanism of pelvic support. So, a very simple thing to understand. If you cough, your levators brace. If you do a Valsalva, your levators balloon. You can try that in your own house. You will find that when you cough, the levators will brace. When you do a Valsalva, your levators will balloon. Therefore, there is no point in asking a woman to push when you're looking for stress incontinence. You really want the woman to cough. When you're looking for genital prolapse, there is no point in asking her to cough because the levator is bracing. You want her to do a Valsalva so that the levator balloons and the prolapse comes down. Something very simple, took me about 10 years to learn. Cough if you want to see incontinence, push if you want to see genital prolapse. Now, what is the prevalence? The prevalence is anywhere between 4 and 35%, depending on the definition used. But I think what is important to understand is the risk factors. Now, aging is inevitable, and therefore aging is a big factor. Your incidence of incontinence does go up as you get older. Obesity somehow plays a role, not by increasing the passive intra-abdominal pressure, but the patient's inability to brace or be muscular enough to generate that closure mechanism when they cough. So obesity has got a problem with recovery from surgery. Obesity has got a problem for muscular activity. Obesity has also got a problem for mobility. So incontinence is affected many ways by obesity. Smoking is a very interesting phenomenon. Smoking actually causes tissue damage. And in our series of nearly 5,700 slings, 98% of the 2% of women who had sling erosions, 98% of them were smokers. It is for some very strange reason, and I don't think it's strange, we believe that people who smoke postoperatively actually have a reduced tissue quality in healing. Pregnancy itself remains a very controversial topic. Cesarean section in the prolonged study and the sweep-up study will tell you that is, does affect early protection to urinary incontinence, but it's not a sustained protection because I think aging and obesity might overtake it. And also you might take up smoking because rearing children is not an easy task. As you can surmise very easily, vaginal birth is not at all protective against urinary stress incontinence. So just please don't start doing cesarean sections to prevent urinary incontinence. That is not the correct message. I think you need to understand that quite clearly. When you take a history, I think you need to do three things. One is take a proper urinary function history. The second is quantification history. And the third is severity and quality of life history. So in urogynecology, we use the terminology BBS, bladder, bowel, sex. So you need to understand that bladder, bowel, sex is the hallmark of urogynecology. You must ask all these three histories, even if a patient is presenting only with urinary symptoms. So I think it's very important to understand. Sujal, would you be able to give me a 5-minute warning, please? Thank you. So, as far as urinary incontinence is concerned, you want to ask about stress incontinence, leak when you cough, laugh, sneeze, urge incontinence, when I get the desire, can't make it on time, mixed incontinence, got both stress and urge, frequency more than 8 to 10 per day, urgency is always wanting to go, nocturia is more than twice per night. The next thing you want to look at is voiding dysfunction, poor stream, dribbling, incomplete emptying, spraying of the stream when you void. Now this is important because if you're going to do surgery, you need to have some idea as to this lady having previous problems with voiding. Of course, you want to look at dysuria, hematuria, digitation. Urinary digitation is not as common as rectal digitation, but if you have a pretty substantial prolapse, women will say I have to digitate my prolapse to actually empty my bladder. Quantification, I think, is very important. You want to really ask them how many pads do they use, are the pads soaked? You can do a pad test, 1 hour, 24-hour pad test, and there are numerous severity or quality of life questionnaires, King's questionnaires. One, you can translate it into many languages. They are available in Hindi, in Arabic, and I can't see any reason why this cannot be done. Of course, they are in French and German, but I'm just trying to talk about the Asian scenario. Bengali could be another one, Bhaskar, for you guys. It's not that complicated. So I think there is no reason why, if you want to really seriously look after a woman with urinary incontinence, that you must make an effort to understand how much this incontinence affects their life. So quantification, severity, quality of life. Urinary incontinence has never killed anyone. It just kills you every day because of embarrassment. So you need to make that effort to try and gauge the woman's severity. What is her bother? You need to get what's the bother factor, okay? Good. So again, this was supposed to be an interactive slide. I was going to say, what do you see when you do genital inspection? What do you see when you do genital examination? How do you do a cough leak test? How do you do POPQ or Borden Walker calcification? And so, ta-da, here's the answers. So when you do genital inspection, I hope most of you examine your patients either in the dorsal position or in the lithotomy position. You want to look for excoriation, atrophy, bulge. A genital examination, like I said, Valsalva for prolapse and hypermobility, cough for leak. Just remember this as a simple rule. Valsalva for bulge and hypermobility, cough for leak. If you want to do a cough leak test, simply put 200 ml in the bladder, never more than that, and do a supine and a standing cough test. And if they leak, I think the diagnosis is pretty clear. You can do prolapse checks using POPQ or Borden Walker. Sometimes it becomes too complicated. I think the important thing to understand is with prolapse, At maximum strain, if the prolapse comes within a centimeter of the hymen, that's stage 3. Stage 3 and stage 4 are the only prolapses one should operate on for the patient. If you want a bigger car or a bigger bank balance, then you can operate on prolapses that are less severe because they are really not prolapses. And please do not ever mention the word mild cystocele or mild rectocele. There is no such thing. Vaginal mobility is not a sin. Vaginal mobility is the hallmark of a functional vagina. Vaginal mobility is not a prolapse. So what you should see is a big bulge coming at the hymen on straining, that's a prolapse. Otherwise, the rest is all normal. So please don't tell the patient you have a mild cystocele, mild rectocele. You are not being ethical. I'm terribly sorry to say this, but that's the truth. So what would you do by way of investigations? Of course, you would do a midstream urine sample. Now, I think it's very important to understand this other concept. No longer do we do midstream urine samples, number one. Number two, no longer is the belief that urine is actually sterile. Urine is not sterile. Urine actually has a lot of bacteria in them. There's a microbiome of its own, plus it has some facultative pathogens. So I think when your pathologist says there is E. coli, I think you need to correlate it with leukocytes, with nitrites, with epithelial cells. If you don't have more than 10 leukocytes, having E. coli in the bladder is like nothing, for example. And you just give them bigger and bigger antibiotics. I know in India, you can just go next to the panwala and get antibiotics, but I think it's not good. It's not good for the bacterial progeny that's going to come for my children's generation. So I think you need to be very careful. Just don't go by bacteria. You can do a PAT test to identify severity. More importantly, of course, people talk of the bladder diary. Bladder diary is very simple.
Last 5 minutes. Just a minute.
5 minutes?
Yes.
Perfect. Bladder diary is basically asking the women simply to keep a record for 2 days, only 2 days. It can't be that bad. How much they drink and how much they weigh. And you'd be surprised how much they drink. There is lassi, there is water, there is whiskey, and then they go, oh no, I don't drink a lot. And then of course, Coca-Cola and coffee, even worse. Far more importantly, however, you need to find out who has intrinsic sphincter deficiency from a treatment point of view and who has hypermobility. How is it diagnosed and why do you need to do that? Again, supposed to be an interactive, but here are the questions. This is probably the second last slide. Intrinsic sphincter deficiency, who has it? Older people, previous incontinence surgery, radiation. How is it diagnosed? Sadly, just through urodynamics. Maximum urethral pressure less than 20. Why is it important to diagnose intrinsic sphincter deficiency? Because it has very poor results with TOT, very poor results with colpoid suspension and physiotherapy. So you will go, I did a really good TOT. Well, I'm sorry, the diagnosis was intrinsic sphincter deficiency. You missed the diagnosis. So your operation might be good, but you didn't choose the right operation for the right patient. I was going to show you my big biceps, but never mind. Hypermobility. Who has got that? Young paras active people. How is it diagnosed? Many, many different ways. Urodynamics, ultrasound scan, physical examination. Why is it important to diagnose? Very good results with TOT, good results with colpoid suspension, good results with physiotherapy. So that's why I put this next question. Should all patients have urodynamics if they complain of SUI? If they have pure SUI, the short answer is no. I think, however, you have to do all other things. You have to do your history, you have to do a PAT test, you got to do a bladder diary, you have to do a cough leak test. Those are also part of the urodynamic paraphernalia. So just having a dual channel cystometry is not urodynamics. But I think if you have an older patient who's had radiation, patient who's had previous surgery, then I think you should do urodynamics, because if you've got intrinsic sphincter deficiency, your TOT is not going to work. Like I said, lots and lots of treatment options, pelvic floor exercises. I say very simply, in my part of the world, we have a concept called death by pelvic floor exercises. They make women do these Kegels, Kegels, Kegels till they start speaking Punjabi, Kegel hai, Kegel hai, because I think if pelvic muscle exercises are going to work, if they're properly targeted, then in 4 months, the patient should be good. If the patient isn't good after 4 months, you should stop pelvic floor exercise and offer them further treatment. Don't blame them by saying you're not doing pelvic exercises correctly. That's very unfair. The rest of it is quite self-explanatory. There's bladder neck support prosthesis, obturator slings, retropubic slings, bulbar suspensions, and bulking agents. I'm going to leave you with some questions here. Mixed stress incontinence. What do you treat first? Intrinsic sphincter deficiency. What's the best treatment? I've given you the answer. Stress incontinence and prolapse. Would you treat it simultaneously or do staged procedures? Occult stress incontinence. What does that mean? I can tell you what it means. It means patient has no symptoms of stress incontinence. She comes to you, she's got genital prolapse, you do urodynamics, you demonstrate stress incontinence by reducing the prolapse. You reveal the incontinence, occult stress incontinence, and what would you do for it? And the last two conundrums are failed sling, what next? And far more importantly, another whole hour, Dr. Sunita, for another webinar, failed trial of void. Lap patients fail trial of void. Pelvic surgical patients fail trial of void. Sling patients fail trial of void. Post-delivery fail trial of void. This can cause permanent bladder damage. It's very important to have these real basics really good, because when you have good basics, then the complex stuff falls automatically into place. So we're just gonna say thank you again. Fantastic opportunity. I hope I just made some sense. I think the basics are very important. Remember, cough, Valsalva, very important. And also understanding the difference between intrinsic sphincter deficiency and hypermobility. Lovely to see you, Gunter. We will, I'll just listen to your talk, and I don't know what the situation with questions is.